Welcome to the funnel effect. Today we are conducting a deep dive into an extremely important review in cardiac intervention. We're analyzing alcohol septal ablation for hypertrophic obstructive cardiomyopathy, a contemporary reappraisal.
That's one by Francesco Polliccia and colleagues, published back in Intervention in 2019. It was on behalf of the Working Group of Interventional Cardiology of the Italian Society of Cardiology.
Exactly, a really key paper.
Yeah, this source is invaluable, really. It synthesizes, 2 decades of data
Mhm.
about a highly specialized and still evolving cardiac procedure. It gives us a solid roadmap to current best practices.
Okay, so let's unpack this for everyone listening. Our mission here is we'll take a shortcut through this complex field. We want to understand alcohol septal ablation ASA.
Right.
It's a minimally invasive therapy used for a serious heart condition, hypertrophic obstructive cardiomyopathy, or HOCM.
HOCM, yeah.
We need to grasp the anatomy, understand the precise mechanism of the procedure itself, and maybe, most importantly, look at the systematic requirement for multidisciplinary expertise. That seems critical for success here.
It absolutely is. It's an intervention that demands the absolute zenith of precision. We'll be exploring the technical how-to, certainly, but also why the success of this treatment is ultimately defined less by the scalpel or the catheter.
And more by the team.
Exactly, more by the team making the call.
Let's begin with the heart condition itself then. Hypertrophic cardiomyopathy, HCM. We often hear this, tragically, cited as a cause of death in young, seemingly healthy athletes. What's the core definition we're working with?
So HCM is defined by unexplained left ventricular hypertrophy. That means the muscular walls of the heart's main pumping chamber, the left ventricle, thicken abnormally.
Without an obvious cause.
Without an underlying cause like, say, high blood pressure or valve disease. And crucially, the source stresses this. It's an extremely heterogeneous disease. Very variable. But its most frequent cause, found in over half of cases, is genetic. Specific mutations in sarcomeric protein genes.
The heart muscle building blocks.
Precisely. The basic contractile units of the heart muscle. And we often see this thickening manifest as asymmetrical septal hypertrophy, meaning the wall between the ventricles, the septum, is the most affected part. It gets disproportionately thick.
And that structural change, that thickening, carries a pretty ominous risk, doesn't it?
It does. The greatest danger is sudden cardiac death, SCD. And as you mentioned, it tragically affects young patients, athletes, who might otherwise seem perfectly healthy, maybe even asymptomatic.
So how do we assess that risk?
Well, the source really hammers this home. The high risk of SCD means routine evaluation using modern, individualized risk calculators is mandatory.
Okay.
They specifically point to the HCM risk SCD model. This model moves beyond just looking at how thick the muscle is. It predicts that individual patients' risk over a 5-year period.
And that guides decisions, like for defibrillators?
Exactly. It guides us on whether they require an implantable cardioverter defibrillator, an ICD, for protection.
Now, the intervention we're focusing on today, ASA, it addresses a specific subset of HCM, right? The obstructive kind, HOCM.
That's right, HCM.
So tell us about the mechanics of this obstruction. Left ventricular outflow tract, obstruction LVO2O. What's actually happening?
LVO2 happens in, over half of all HCM cases. And what makes it so complex is that it's dynamic.
Dynamic, meaning it comes and goes.
Sort of, yeah. It can range from being present all the time, even at rest, to only showing up when the heart is under stress.
Like during exercise.
Exactly. Physical exercise or even pharmacological stimulation in the cath lab. This dynamic nature often correlates directly with how the patient's symptoms fluctuate.
So you do an echocardiogram, the ultrasound of the heart, that shows the asymmetrical thickening. But we need to understand the moving parts, the actual blockage. What causes the blood flow leaving the left ventricle to get choked off?
The primary mechanism is something called systolic anterior motion, or SAM, SAM of the mitral valve.
Okay, Sam.
During systole, that's when the heart contracts to pump blood out. The anterior leaflet of the mitral valve, the valve between the left atrium and left ventricle, moves forward abnormally.
Towards the septum.
Precisely. It moves forward and actually collides with that thickened interventricular septum. That physical contact, mitral valve leaflet hitting the septum, that's the bottleneck. That's the obstruction.
I seem to recall older explanations focused heavily on something called the Venturi effect, like a suction force.
Yeah, that was the initial thinking, and it definitely plays a role. The Venturi effect is real. It's the negative pressure created when blood flow speeds up through that narrowed gap between the septum and the leaflet. And that negative pressure does tend to pull or elevate the mitral valve leaflet upwards.
But that's not the whole story.
Not quite. The current sort of unifying hypothesis that the source detail suggests it's more synergistic. The Venturi effect might get the leaflet moving, lifts it up slightly.
Right.
But the real driver seems to be drag forces.
Drag forces, like the blood flow itself.
Exactly. These are the mechanical forces of the high-velocity blood pushing against the leaflet. These drag forces facilitate the anterior displacement, effectively pushing the leaflets forward into the outflow tract, cementing that contact.
Wow. Okay, so it's both suction and a forceful push. That combination really locks the mitral valve leaflet against the septum.
That's the idea. And this dual mechanism creates that severe LVO2. Plus, it often leads to secondary problems like its eccentric mitral regurgitation. Because the valve isn't closing properly when it's pulled forward, it compounds the issue.
That's a much more robust understanding of the fluid dynamics involved than just simple suction.
It is. And it clarifies why just thinning the septum a little bit might not always be enough. You need to change the geometry sufficiently to disrupt both the venturi pull and the drag push.
Now, here's something fascinating the source points out. While this obstruction clearly dictates the patient's immediate clinical status, how bad their symptoms are, their NYHA class.
Yeah, breathlessness, chest pain, fainting.
Right. The source notes its overall prognostic role, its link to long-term survival, is actually debated.
It is, yeah.
If HCM-related death rates are similar in patients with or without LVOTO, doesn't that kind of raise the question? Are interventions like ASA just about symptom relief? Are they just cosmetic in a way?
That is a really critical question, and it's a fair one. The data does suggest that the obstruction itself, while absolutely devastating to someone's quality of life, might not be the primary driver of the most lethal event, which is often SCD from arrhythmias.
Okay.
However, the goal of intervention here is profound symptom alleviation. We're talking about patients who are severely limited, they can't walk across a room without chest pain or shortness of breath, maybe they're fainting. Improving their quality of life, their functional capacity, that's the undisputed immediate priority. It's life-changing for them.
Makes sense. So before we even consider jumping to an invasive procedure like ASA, what does the initial medical management look like for LVOTO?
Right, you always start with optimal medical therapy, trying to manage it with drugs first. This typically includes beta blockers.
Slow the heart rate.
Yep. Non-dihydropyridine calcium channel antagonists like verapamil or diltiazem.
Also slow the heart, reduce contractility.
Exactly. And also disopyramide, which has strong negative inotropic effects. It reduces the force of contraction. All these agents work primarily by reducing the heart rate and the force of contraction.
Giving the outflow tract more time and space.
Precisely. Gives it more time to empty and less forceful ejection, which can lessen the SAM and the obstruction.
What if those drugs don't work or the side effects are too much?
Well, if symptoms remain refractory despite maximally tolerated doses of these drugs, then another option before invasive therapy is dual-chamber pacing.
Pacing, how does that help?
In selected cases, pacing the right ventricle slightly before the left ventricle can change the sequence of contraction. It can sometimes make the septum contract a bit earlier, altering the timing just enough to reduce the SAM and the LVOTO during systole. It's a feasible strategy for some. So when a patient remains severely symptomatic despite exhausting all these medical and maybe pacing options, that's when we have to start considering structural intervention.
And that leads us directly to alcohol septal ablation, ASA.
ASA.
Now, injecting pure alcohol, essentially ethanol, into the heart muscle to intentionally cause a localized heart attack. I mean, it sounds incredibly radical on the face of it. Where did this idea even come from?
It does sound radical, doesn't it? But the historical link is fascinating because, as you hinted, it wasn't originally developed for HOCM at all.
Oh, no.
The concept of generating a controlled infarct, a small targeted area of dead tissue in the hypertrophic septum, actually derived from earlier electrophysiology studies, work done by Brugada back in the 1980s.
Brugada, like the Brugada syndrome.
The very same. They were experimenting with injecting intracoronary alcohol, but for a completely different reason, to treat ventricular arrhythmias. They were trying to ablate or destroy specific bits of heart tissue that were causing dangerous electrical rhythms.
Okay. So someone saw that precise targeting mechanism used for an electrical problem and thought, wait a minute, Could we use this for a structural problem?
That's exactly the leap. That's the aha moment of interventional cardiology right there.
Yeah.
They realized they could potentially use the same technique to target and eliminate the specific bulge of muscle causing the outflow obstruction in HOCM.
When was it first actually used for HOCM then?
The first proper report of percutaneous ASA, specifically for drug-resistant HOCM, was published in 1995.
And what did they find?
The results were pretty dramatic. They reported immediate resolution, or near resolution, of the subaortic stenosis, the narrowing and rapid symptom improvement right after the procedure. That initial report was a real paradigm shift. It offered a potentially much less invasive option compared to the standard treatment at the time, which was open heart surgery.
Surgical septal myectomy.
Right. Open heart surgery to physically shave away the excess muscle.
So let's zero in on the exact rationale for ASA. How does creating a small scar, a dead spot, actually relieve what's often a massive obstruction?
The core goal is to create a controlled, localized, iatrogenic, meaning medically induced infarction. A small heart attack, essentially.
Right in the basal septum.
Precisely. Specifically targeting the area of the septum that's bulging into the outflow tract and making contact with that anterior mitral valve leaflet during SAM. The alcohol acts almost like a chemical cauterizing agent.
It kills the cells locally.
It causes localized cell death, yes. So we convert that thick, viable, obstructive heart muscle into a thin, akinetic scar. Akinetic meaning it doesn't contract anymore.
And then what happens to the scar?
This is key. Over the following weeks and months, that scar tissue undergoes remodeling and shrinkage. It contracts. And this shrinking effectively pulls the septal muscle mass away from the path of the anterior mitral valve leaflet.
Creating more space.
Exactly. It increases the space in the outflow tract, reduces or eliminates the SAM, and thereby relieves the LVOTO.
It sounds like a highly sophisticated catheter-based method of internal remodeling then, offering an attractive middle ground between drugs and major surgery.
That's how it's positioned, yes. An appealing, minimally invasive alternative to surgical septal myectomy. Now, myectomy is still considered by many the gold standard, offering perhaps a more definitive mechanical correction.
Because they physically remove the tissue?
They physically remove it, but ASA offers a much faster recovery time, avoids the sternotomy, cracking the chest open, and the risks associated with open heart surgery.
But there's always a but.
There's always a but. The source emphasizes very clearly that the ultimate success rate of ASA is profoundly dependent on two things: very careful patient selection and the high level of experience of the operating center. It's not a procedure to be done lightly or infrequently.
Okay, that makes perfect sense. Since this procedure involves causing intentional heart damage, albeit controlled, the selection criteria must be incredibly strict. Who actually makes the ideal clinical candidate for ASA?
Yeah, the threshold for intervening invasively is very high. ASA is really reserved for patients with severe debilitating symptoms. We're talking NYHA class 3 or 4 heart failure symptoms.
Meaning short of breath with minimal activity or even at rest.
Right. Or severe angina, chest pain, that's Canadian Cardiovascular Society grade 3 or 4, or recurrent episodes of presyncope, feeling like you're going to pass out, or actual syncope, fainting spells.
And these symptoms have to significantly interfere with their life.
Profoundly interfere with their daily life, yes. And this is critical despite having already been tried on maximally tolerated medical therapy. You absolutely have to exhaust the medical options first. That's non-negotiable.
Are there groups where ASA is particularly controversial or generally avoided?
Yes, definitely. The lack of really long-term data, decades-long data, makes ASA quite controversial in children and adolescents. We just don't fully understand how inducing a septal scar might affect a developing heart over 30, 40, 50 years.
That makes sense. Any others?
It's also debated for patients who are only mildly symptomatic, even if, paradoxically, they have a severe LVOTO measured on echo.
Why is that?
Well, if they aren't significantly limited in their daily function, the inherent risks of the procedure, which we'll get into, might outweigh the potential symptomatic benefit. It's a risk-benefit calculation.
And you have to be sure the symptoms are actually from the HOCM, right?
Absolutely critical point. The pre-intervention workup must rigorously exclude other conditions that could mimic HOCM symptoms. Things like underlying thyroid dysfunction, significant respiratory disease, even severe anemia. You don't want to misdiagnose and subject someone to ASA unnecessarily.
Okay, so beyond the clinical picture, the patient's actual heart anatomy has to cooperate perfectly, doesn't it? If the structure isn't right, the procedure might just be impossible.
That's the crucial stage 2 screening, exactly. We have to meticulously evaluate the outflow tract geometry, the specific morphology or shape of the septum, and the mitral valve apparatus itself. This detailed anatomical assessment, usually with high-quality echocardiography and sometimes cardiac MRI, is where we predict the actual feasibility of ASA for that individual.
Are there anatomical situations where surgery, myectomy, is just clearly the better option?
Yes. For instance, if a patient has HOCM, but also needs another cardiac surgical procedure anyway, maybe significant coronary artery disease needing bypass grafting, or perhaps intrinsic mitral valve disease needing repair or replacement.
Then you do it all at once surgically.
Exactly. It makes far more sense to address the septal hypertrophy with surgical myectomy at the same time as the other necessary surgery, rather than doing ASA followed by a separate open heart operation later.
The sources mention a specific anatomical cutoff regarding how thick the septum can be. Why is that measurement so important?
Right. The European guidelines propose a sort of suggested cutoff for septal thickness for ASA, less than 30 millimeters.
Less than 30 millimeter. Why that number?
The main reason for this threshold is to minimize the risk of a really catastrophic complication, creating an iatrogenic ventricular septal defect, or VSD.
Punching a hole through the septum.
Essentially, yes. If the septum is extremely thick, it might be structurally more vulnerable, and the alcohol could potentially necrose or kill tissue right through the wall, creating a hole between the left and right ventricles. So staying below that 30 millimeter threshold is considered a major safety precaution. It's based on expert consensus, not hard trial data, but it's a widely accepted guideline.
Okay, so let's say we have a patient who fits the clinical picture, symptoms are severe, drugs haven't worked, and the septal thickness is appropriate. Now, the absolute cornerstone seems to be finding the right target coronary vessel. We need a perfect map, right?
Correct. You cannot proceed without knowing exactly which blood vessel supplies the precise area of the septum you want to ablate. So, invasive coronary angiography, or sometimes C-key coronary angiography, is mandatory before ASA.
Even if they don't have chest pain suggesting blocked arteries.
Even if they have no symptoms of angina, yes. You need to map the coronary circulation thoroughly and specifically identify the septal branches, the small arteries that dive into the interventricular septum. The target septal perforator branch must be identified with supreme accuracy.
Which specific vessel are operators usually looking for?
Typically, we're looking for the first major septal perforator artery. This usually arises from the left anterior descending artery, the LAD, which is a main coronary artery running down the front of the heart.
And that first septal supplies the key area.
It often perfuses that critical basal part of the septum, the bit that's bulging into the outflow tract and causing the obstruction. However, you can't just assume it's the first one. Operators have to meticulously screen all the septal branches, including any that might arise from other coronary arteries, like the circumflex, or even the right coronary artery in rare cases. The anatomically optimal branch isn't always the first one you see.
So what are the absolute anatomical roadblocks here? Situations where the operator looks at the angiogram and says, nope, ASA is not feasible, or this patient needs surgery instead.
For several clear contraindications. First, if the patient already has significant scar tissue in that basal septal area, maybe from a prior unrelated heart attack.
Because the alcohol needs viable tissue to work on.
Exactly. If it's already scarred, the alcohol won't have much effect, and ASA efficacy will likely be inadequate. Second, and this is probably the most important anatomical contraindication, if the target septal branch, the one that looks like it's going to the right spot, also supplies blood to critical non-target structures.
Like what kind of structures?
We specifically screen very carefully to ensure that vessel does not feed significant portions of the free wall of the left ventricle or the papillary muscle.
Which control the mitral valve.
Precisely. Or any structures belonging to the right ventricle. If that target vessel perfuses any of those areas, injecting alcohol would cause massive, unintended non-target infarction. That could lead to acute heart failure, valve dysfunction, even cardiac rupture. It's an absolute no-go.
What if there just isn't one good vessel?
That's another major limitation. Sometimes, instead of one suitable septal artery, there's just a network of multiple tiny sub-millimeter branches, too small to safely catheterize and inject. Or, as we just discussed, if every identifiable branch also seems to supply non-target tissue. In those situations, ASA is rendered unfeasible, and the patient would typically be referred for surgical myectomy consideration.
So this whole diagnostic phase is really an elimination process, isn't it? You're meticulously searching for that very specific needle in the haystack. A coronary artery branch that is large enough to get a catheter into feeds only the obstructive part of the basal septum and, crucially, does nothing else.
Precision, precision, precision.
Yeah.
That's the name of the game in selecting the right anatomy for ASA.
All right, let's move into the cath lab now. We've got the perfect candidate, clinically and anatomically. The target vessel is mapped out. How do the operators actually start the ASA procedure itself?
Okay, first step is getting access to the arterial system. This is usually done via the radial artery in the wrist or the femoral artery in the groin.
Is one preferred?
The radial approach is increasingly favored. Studies suggest similar success rates for the procedure itself, but the radial approach has been associated with lower rates of vascular complications at the access site, bleeding, hematomas, that sort of thing.
Makes sense. What happens next?
An arterial sheath is placed to maintain access. And then, crucially, before anything else really happens invasively, a temporary prophylactic pacemaker wire is inserted, usually placed via a vein into the right ventricle.
That proactive placement of a temporary pacemaker right at the start, I mean, that tells you everything you need to know about the inherent risks involved, doesn't it? Why the immediate need for that backup?
It's purely down to anatomy. As we discussed, those septal perforator arteries run extremely close to the heart's electrical conduction system. Specifically, the bundle of His and the right bundle branch, which are critical for coordinating the heartbeat.
So the alcohol could damage them.
But the moment you start injecting alcohol and necrotizing tissue in that region, you run a significant risk of causing transient or sometimes permanent complete atrioventricular block, AV block. The heart's upper and lower chambers stop communicating electrically. That temporary pacemaker is the patient's immediate electrical safety net, ready to take over if needed.
And I assume the procedure is painful.
Oh, yes. Intentionally causing an infarct, even a small one, is predictably extremely painful. So patients receive strong analgesic drugs, often intravenous morphine or similar potent painkillers, before and during the alcohol injection to manage that pain.
Okay, pacemaker in, pain relief on board. What's the next step involving the coronary arteries?
After performing an initial diagnostic catheterization to measure the baseline pressure gradient across the left ventricular outflow tract to have a starting point, the operator then engages the target coronary artery, usually the LAD, with a guide catheter.
And then into the specific septal branch.
Yes. Then, a specialized catheter called an over-the-wire or OTW balloon catheter is very carefully advanced over a guide wire into the chosen target septal vessel.
Why an OTW balloon catheter specifically?
The OTW design is vital. It allows the operator to maintain guide wire access into the vessel for stability and potential repositioning. But more importantly, it has an inflatable balloon near the tip. This balloon can be inflated to completely occlude the septal vessel during the critical safety checks and, most importantly, during the alcohol injection phase itself.
Right, sealing off the vessel. This brings us to those mandatory safety checks you mentioned earlier, the non-negotiable steps to ensure the alcohol goes only where it's intended. What's the first check focused on collateral blood flow?
The first mandatory safety check involves performing coronary angiography while that OTW balloon is inflated inside the target septal vessel.
Blocking flow forwards.
Exactly, blocking forward flow. The purpose here is to inject contrast dye proximal to the balloon and see if it leaks or backfills into any other coronary arteries, either other branches of the left coronary system or even vessels in the right coronary system via tiny connecting channels called septal collaterals.
If the contrast leaks.
The contrast leaks or fills other vessels, it means the alcohol will leak too. The presence of any significant collateral filling distal to the planned injection site is a major red flag. It signals a risk of non-target infarction and usually requires deflating the balloon, repositioning it, perhaps trying a different size balloon, or potentially abandoning that specific branch altogether if a safe seal can't be achieved.
Okay, so let's assume the angiography shows the vessel is perfectly isolated, no leaks. What's the second major safety check?
Using ultrasound. Yes, this is myocardial contrast echocardiography, or MCE. This is an absolutely critical intraprocedural guidance step. It uses echocardiography, ultrasound imaging of the heart, performed simultaneously with the catheter procedure.
But using a special contrast agent?
Correct. Instead of the standard iodine-based contrast used for angiography, MCE uses a specialized contrast agent. The source mentions gelafundin as an example, which is technically a plasma volume expander.
Why gelafundin or something similar?
When agents like gelafundin are agitated, often just mixed with a tiny bit of air or saline in the syringe, They create stable microbubbles. These microbubbles are highly echogenic. They show up very brightly on the ultrasound screen.
So you inject these microbubbles.
Yes, a small amount of this microbubble contrast is slowly injected to the central lumen of the OTW balloon catheter into the septal artery.
While the balloon is still inflated.
While the balloon is still inflated, occluding the vessel, the operator, and usually a dedicated echocardiographer, watches the echo screen intently to see exactly where those bright microbubbles appear within the heart muscle.
What are they looking for? Or rather, what do they not want to see?
They want to see the contrast stain localized precisely to that basal anterior septum, the target area responsible for the obstruction. What constitutes an absolute failure, an absolute contraindication to proceeding with the alcohol, is seeing that contrast misplaced.
Misplaced where?
If the echo shows the contrast traveling to, say, the inferior wall of the left ventricle or down into the papillary muscles, or perhaps most critically, if it crosses over and appears in the wall or structures of the right ventricle.
Because that confirms a pathway to non-target tissue.
Exactly. It confirms that the vessel, despite looking okay on angio, actually supplies blood to areas you absolutely do not want to infarct. If misplacement is seen, the alcohol infusion must be aborted for that vessel. The source notes that in particularly challenging cases, maybe with complex anatomy, more advanced techniques like intercardiac echo, ICE, putting a tiny ultrasound probe inside the heart, or 3D contrast echo can provide even clearer guidance.
Okay, a very rigorous two-step check. Let's assume both safety checks pass no collateral flow on angio, perfect contrast localization on MCE. Now we finally move to the moment of truth. The ethanol infusion itself, how much alcohol is actually used?
It's a surprisingly small amount, usually just 1 to 4 milliliters of absolute sterile ethanol. The exact dose often depends on the size of the vessel and the thickness of the septum, but it's typically in that low range.
And how is it injected? Quickly.
No, very slowly and carefully. It's infused over a period of 1 to 5 minutes. Again, the slow rate is deliberate.
Why slow?
It helps ensure controlled delivery and minimizes the pressure, which might reduce the chance of forcing alcohol through tiny unseen collaterals. The absolute key technical mandate during this infusion is that the OTW balloon must remain firmly placed and fully inflated.
Maintaining that seal.
Maintaining that complete occlusion of the vessel throughout the entire infusion process is paramount. This prevents any seepage or traversal of the alcohol back into the main coronary artery or down through unexpected collaterals. Aggressive or rapid injection is strictly discouraged precisely because it increases the risk of overcoming the balloon seal or recruiting collaterals, potentially leading to extensive and unintended myocardial damage.
It really sounds like the most technically demanding and probably nerve-wracking few minutes of the entire procedure for the operator.
It absolutely is. Intense focus is required. Once the predetermined dose of alcohol has been slowly infused, the balloon is kept inflated for another minute or so, then carefully deflated and removed along with the wire.
And the final step?
The final step is a repeat coronary angiography of the main coronary artery. This is done to confirm the procedural result and exclude any immediate complications, like dissection or thrombosis of the main vessel. What you should see is the stump of the septal artery that was just treated. It should now be occluded, demonstrating the alcohol-induced cessation of blood flow to that targeted area.
All right, the procedure is finished, the patient is recovering. How do we actually define success for ASA? What are we aiming for, and what are the typical efficacy rates reported?
Success is really defined in 2 ways, both clinically and hemodynamically. Clinically, we're looking for marked symptom alleviation, a significant improvement in the patient's NYHA functional class, meaning less shortness of breath, less angina.
They feel better.
They feel significantly better. Their quality of life improves. Hemodynamically, the goal is a significant and, importantly, sustained reduction in that left ventricular outflow tract gradient. Ideally, we want to see that peak gradient fall to below 20 millimeters of mercury at the 6-month follow-up assessment.
Below 20 millimillimeter Hg, and how often is that achieved?
The efficacy rates are generally quite high. Multinational studies and registry data consistently demonstrate hemodynamic success, achieving that gradient reduction in about 80 to 90% of well-selected cases performed in experienced centers.
That sounds extremely effective, especially for a minimally invasive procedure compared to open heart surgery. Is that success generally durable in the long term?
It is often durable, yes, but perhaps not quite as definitively durable as surgical myectomy in some cases. The data shows that around 10 to 20% of patients who initially have a successful ASA eventually require a reintervention later on.
A repeat procedure, either another ASA or surgery.
Exactly. Either a repeat ASA targeting the same or a different septal branch, or ultimately converting to surgical myectomy if ASA fails or the obstruction recurs significantly. And interestingly, this need for reintervention seems to be somewhat more frequent in younger patients.
Why might that be?
It's not entirely clear. It could be related to ongoing hypertrophic remodeling in younger hearts, or perhaps the initial ablation wasn't quite extensive enough to prevent recurrence over many years. It highlights the need for diligent, long-term follow-up, especially in the younger population.
Now, here's something I found really counterintuitive in the source material. When this controlled infarct is created by the alcohol, clinicians measure the spike in cardiac enzymes in the blood afterwards, things like creatine kinase, CK, or troponin.
Right. Biomarkers of heart muscle damage.
Since this spike reflects the size of the myocardial necrosis, the amount of tissue damaged, you'd intuitively think that a larger enzyme spike would predict a better outcome, a greater reduction in the gradient, right? More damage equals more shrinkage equals less obstruction.
It seems logical, doesn't it? But counterintuitively, no. The source explicitly notes that while the peak cardiac enzyme levels do correlate reasonably well with the overall area of myocardial necrosis, the size of the scar created,
Yeah.
they have not been consistently proven to predict the ultimate procedural success, meaning the final, sustained reduction of the LVOT gradient at follow-up or the degree of symptom improvement.
So a bigger scar doesn't necessarily mean a better result?
Apparently not. The efficacy seems to rely more on the location and strategic placement of the scar, ensuring it occurs precisely in the right spot to relieve the mitral septal contact, rather than just the absolute volume of tissue infarcted.
That's a really critical distinction. The scar needs to be placed functionally, strategically, not just sized extensively.
Exactly right. And we also need to consider the flip side. What happens if the procedure doesn't achieve that target gradient reduction? The source points out that residual LVO2O, having a persistently high gradient after ASA, is independently associated with an increased risk of future adverse events, including arrhythmias and potential mortality.
So hitting that 20 millimilli Hg gradient target isn't just about symptoms, it has prognostic importance too.
It seems to, yes. Getting that gradient down is important for both quality of life and potentially long-term outlook.
Okay, let's talk about the unavoidable downside, complications. You mentioned the need for that temporary pacemaker right at the start due to the risk of conduction block. How often does that risk actually translate into a permanent problem needing a permanent pacemaker?
This remains the single most frequent and significant procedural complication of ASA, transient or, unfortunately, permanent complete AV block. The incidence requiring lifelong permanent pacemaker implantation is substantial. It consistently lands somewhere in the range of 10 to 20% across various large studies and registries.
Wow. A 1 in 10, or even up to 1 in 5, chance of needing a permanent pacemaker implanted as a direct result of the procedure. That's a high complication rate for an elective intervention.
It is undeniably high, and is the major Achilles heel of ASA compared to surgery. It's almost entirely due to that unavoidable anatomical proximity we discussed, the septal perforator arteries running right alongside or through the heart's critical electrical wiring in the septum. Infarction in this region frequently damages the His bundle or the right bundle branch.
And it might not happen immediately.
Correct. AV block can sometimes manifest hours or even days after the procedure as the tissue swelling and inflammation evolve. That's why the temporary prophylactic pacemaker monitoring often needs to be continued for several days, sometimes up to 6 days post-procedure, before it's deemed safe to remove. If significant conduction disturbances persist beyond that point, then permanent pacemaker implantation is indicated.
Okay, this inevitably brings us to the elephant in the room, the comparison with the alternative surgical septal myectomy. If ASA carries such a significant risk of pacemaker dependency, plus that 10-20% reintervention rate, why hasn't surgery just completely displaced it? Why is ASA still a recommended option?
That really is the core of the ongoing debate and the controversy surrounding septal reduction therapy. You're right, surgical septal myectomy, when performed at experienced high-volume surgical centers, is highly effective and generally carries a lower risk of both permanent pacemaker implantation, often well under 5% in top centers, and a lower rate of needing reintervention later on.
So surgery seems technically superior in those aspects.
From those perspectives, yes, it's often viewed as providing a more definitive and potentially more durable structural correction because the surgeon physically removes the obstructing muscle under direct vision.
The trade-off.
The trade-off is that myectomy is open heart surgery. It requires a sternotomy, cardiopulmonary bypass, a longer hospital stay, and a significantly longer recovery period compared to ASA. ASA, being minimally invasive via catheter, offers much faster initial recovery and avoids the morbidity associated with major cardiac surgery. This makes it a particularly appealing option for certain patients, perhaps those who are older, frailer, have other comorbidities that increase surgical risk, or simply have a strong preference to avoid open-heart surgery if possible.
Beyond pacemakers and reinterventions, the source also raises another serious concern, a potential link between ASA and an increased long-term risk of ventricular arrhythmias compared to myectomy. How significant is this debate?
It is highly significant and remains an area of active discussion and research. Concerns have certainly been raised, with some authors reporting data suggesting potentially a five-fold increase in the risk of significant ventricular arrhythmias, like ventricular tachycardia, occurring late after ASA compared to post-myectomy patients.
What's the proposed mechanism for that? The scar tissue.
Exactly. The hypothesis ties directly back to the iatrogenic scar tissue created by the alcohol. The theory is that a larger, perhaps more heterogeneous or transmural infarct scar may be resulting from using a slightly higher alcohol dose or suboptimal vessel selection could become an arrhythmogenic substrate, basically a source of electrical instability that could trigger dangerous ventricular rhythms years down the line.
So that potential long-term electrical risk needs careful consideration.
Absolutely. It necessitates rigorous patient screening beforehand, potentially favoring myectomy in younger patients or those with pre-existing arrhythmias. It also emphasizes the importance of using the lowest effective alcohol dose during the ASA procedure and underscores the need for detailed long-term arrhythmic surveillance and follow-up after ASA.
So, in essence, the choice between ASA myectomy involves trading the invasiveness, recovery time, and immediate risks of open heart surgery against the higher risks of late complications, specifically pacemakers and potentially arrhythmias associated with ASA. That makes the decision-making process incredibly nuanced and patient-specific.
Precisely. It requires a very careful, balanced discussion between the medical team and the patient, weighing the pros and cons of definitive structural correction versus a minimally invasive approach with its own distinct risk profile. There's often no single right answer. It depends heavily on the individual patient's anatomy, clinical status, risk tolerance, and preferences. And given all of this complexity, the intricate LVO toe mechanism, the strict anatomical prerequisites, the very different risk-benefit profiles of ASA versus myectomy, the source material strongly argues that the crucial choice of therapy cannot and should not be made by one physician acting alone.
Right. This sounds like a perfect application of the heart team concept we hear about in other areas of cardiology, like complex valve disease. We're talking about true personalized medicine guided by a multidisciplinary team.
That's exactly the model advocated. The decision-making process must be carried out by an experienced, multidisciplinary cardiomyopathy team. This team approach mirrors the success seen with heart teams for TAVR or complex coronary bypass decisions. And absolutely central to this is shared decision-making with the patient, openly discussing the risks, benefits, uncertainties, and alternatives of each approach.
Why is it considered crucial that this cardiomyopathy team includes a cardiac surgeon, even if the primary intervention being considered might be the minimally invasive ASA procedure performed by an interventionalist?
The inclusion of an experienced cardiac surgeon is vital for ensuring impartiality and providing a truly comprehensive perspective. Alongside the clinical cardiologist managing the patient and the interventional cardiologist who would perform the ASA, the surgeon can objectively present the myectomy option, realistically assess the patient's individual surgical risk, and ensure that the team isn't inadvertently steering the patient toward ASA simply because that's the intervention readily available at that institution or the specialty of the physician leading the discussion.
It guarantees all options are fairly considered.
It guarantees the most appropriate treatment for that specific patient is chosen, not just the most convenient or most familiar treatment for the local team.
Now, connecting this need for specialized teams back to the bigger picture. The source repeatedly highlights that operator experience, and perhaps even more so, institutional volume. How many of these procedures a center performs are the greatest predictors of both safety and efficacy for ASA.
This is arguably the single most critical takeaway message from this contemporary reappraisal. The outcomes for both ASA and surgical myectomy are highly dependent on the experience level of the institution and the individual operators.
And high volume equals better results.
Consistently, yes.
Hmm.
Specifically for ASA, high-volume centers, those performing a significant number of these procedures per year, are consistently associated with better cardiovascular survival rates, superior hemodynamic results, meaning better gradient reduction, better clinical outcomes, more symptom improvement, and crucially, a lower occurrence of procedural complications.
Fewer pacemakers.
Fewer pacemakers needed and less need for repeat interventions down the road. High volume translates directly into higher safety and better efficacy.
This really validates the argument for centralizing this type of specialized care, doesn't it?
It absolutely does. In fact, the American guidelines formally recommend that septal reduction therapy, whether ASA or myectomy, should only be performed by experienced operators working within a comprehensive HCM clinical program, essentially, a dedicated center of excellence.
What's the reality on the ground, though? Are these centers widely available?
Unfortunately, the troubling reality noted by the source is that while such high-volume centers exist, they are relatively few and far between. Most hospitals that offer ASA actually perform these procedures at a relatively low volume. This leads to significant variability in outcomes across different institutions and potentially exposes patients treated at lower volume centers to unnecessary risks and suboptimal results.
So perhaps the immediate challenge isn't so much about inventing new technology for ASA, but more about fixing the system, improving implementation, and ensuring patients actually get funneled towards the specialized care they need.
You've hit the nail on the head. That's the central conclusion emerging from this reappraisal. The establishment of more dedicated, high-volume cardiomyopathy centers and the standardization and consistent application of the multidisciplinary heart team approach across healthcare systems. These are likely the most critical steps needed right now to improve outcomes for this special patient population.
Before we wrap up, are there any technical innovations actually on the horizon for septal reduction itself? Anything that might help mitigate some of the persistent risks of ASA, particularly that high rate of AV block?
Yes, there is ongoing research exploring alternative methods to create that necessary localized septal scar, but perhaps without using alcohol, which, being a liquid, can diffuse somewhat rapidly and unpredictably towards the nearby conduction system.
Like what kind of alternatives?
The most promising alternative, highlighted in the source, is percutaneous intramyocardial septal radiofrequency ablation.
Using heat energy instead of alcohol.
Exactly. Similar to how radiofrequency energy is used to treat arrhythmias, this technique involves advancing a specialized catheter into the septum and using controlled thermal energy heat to create a precise, localized area of ablation. Early feasibility studies are showing promising results, suggesting it might be safe and effective in reducing the gradient, potentially with a very low risk for causing conduction system injury.
Avoiding the pacemaker issue almost entirely.
That's the hope, yes.
Yes.
If radiofrequency ablation could maintain the efficacy of gradient reduction while significantly reducing or eliminating the major complication risk of AV block, that would be a true game changer for percutaneous septal reduction therapy.
Definitely something to watch.
Absolutely. Additionally, the source suggests that further integration and refinement of imaging techniques will also be key moving forward. Things like routine pre-procedural CT coronary angiography to get an even more detailed 3D map of the septal arteries, and more widespread use of advanced intraprocedural guidance like 3D echo or intracardiac echo, ICE. These could further improve procedural safety and efficacy, especially for those patients who have particularly challenging or aberrant coronary anatomy. But for the time being, the expert team and high volume remain the primary guarantors of safety and success. #outro.
Okay, so to try and synthesize everything we've covered in this deep dive.
Yeah.
Alcohol septal ablation, ASA, has certainly proven itself over more than 2 decades now to be an effective, relatively safe, and importantly, minimally invasive alternative to open-heart surgical myectomy for patients suffering from severely refractory symptoms of hypertrophic obstructive cardiomyopathy.
That's a fair summary. However, it's crucial to remember the procedure carries distinct and significant disadvantages compared to surgery, namely those considerably higher rates of permanent pacemaker implantation and the greater likelihood of needing reintervention over the long term. Its optimal utilization, therefore, is fundamentally dependent on several key factors operating together. Sophisticated patient selection based on both clinical need and precise anatomy.
Meticulous procedural execution.
Absolutely meticulous execution using essential safety techniques like myocardial contrast, echocardiography for confirmation, and perhaps overshadowing everything else, the absolute necessity of a dedicated, experienced, multidisciplinary cardiomyopathy team working within a specialized, high-volume center of excellence.
It seems the future success and refinement of this intervention rely less on tweaking the technology itself and far more on getting the implementation strategy right across the board, establishing these high-volume cardiomyopathy centers and truly standardizing that multidisciplinary heart team decision-making process seem to be the most critical steps forward.
I agree completely. And this really raises an important, perhaps provocative question for you, the listener, to mull over as we finish. Given this clear and proven link between high hospital volume and achieving the best possible outcomes, both in terms of success and safety, for complex, specialized procedures like ASA, how can our health systems realistically overcome the significant geographical barriers, the economic pressures, the referral pathway challenges, to ensure that every patient diagnosed with symptomatic HOCM is seamlessly connected to one of these necessary centers of excellence, even if it requires significant travel, crossing regional boundaries, or navigating complex insurance hurdles?
That gap between the recognized importance of expertise and volume and the practical reality of patient access, that remains the ultimate systemic challenge we need to solve, doesn't it?
It really does. Ensuring equitable access to high-quality specialized care is paramount.
Thank you for watching The Funnel Effect.